Okay. Anna, can you hear me all right? Hello, Anna. Earth to Anna, can you hear me? You're gonna have to unmute yourself, hon, for me to hear you. Oh, okay. There, yes. All right. All right. We've got 1 minute before I'll start, so. Sorry? No, because I forgot to write one. Yeah, I forgot, completely forgot. Well, I have to get my other class's final written early, so I was spent the whole afternoon working on that.
This one's for you. Bye.
Okay, well, here's a quiz question for you. Um, which group of cell wall inhibiting antibiotics are the broadest spectrum? So go ahead and rehearse them in your head. There's the beta-lactams, which consists of the penicillins. So the penicillins include the so-called natural penicillins, the aminopenicillins, the anti-staphylococcal penicillins, and the anti-pseudomonal penicillins. They're the cephalosporins. First, second, third, fourth, fifth generation. They're the carbapenems. They're the monobactams, and they're the glycopeptides. So out of those groups, which ones are the broadest spectrum? Nope. The answer is carbapenems. Carbapenems are broad spectrum, very broad spectrum. If you want to throw the kitchen sink at something, you use carbapenems. So if you have a mixed infection, say somebody's appendix burst, and that invariably will cause a mixed infection, that will cause peritonitis, that can be very severe. That can kill the patient. You need to throw the kitchen sink at it. You take out the carbapenems. You have a patient with some sort of, say they have a stomach ulcer and it perforates. And now the patient has pleuritis because you've got infection of the lung and there's infection underneath the diaphragm as well. And it irritates the phrenic nerve and their shoulders are really hurting because of referred pain. What are you going to use? Because you need to throw the kitchen sink at it? Carbapenems. Right. So when it comes to carbapenems, think kitchen sink. Kitchen sink, broad spectrum, broad spectrum. Which of the following antibiotics has more specificity for gram-positive bacteria? A, cefazolin, B, cefepime, C, ceftazidime, D, ceftriaxone, or E, amoxicillin. Which one of those, and please don't ask me to repeat them, which one of those, I have to remember what they are, and which one of those has the most activity towards gram-positive bacteria? Sorry? No. Moxicillin has some activity against some gram-negative bacteria. I did not. But if it was in there, that'd be a good choice, but it wasn't. Neener, neener, neener.
I don't remember all of that.
Okay, remember, first generation cephalosporins, very active against gram positives. As you start to get higher, they have less activity towards gram positives, more towards gram negatives. So cefazolin is first generation. So it's going to be most active against gram positives. So the answer would be cefazolin. Cefazolin. Which antibiotic is very effective against Pseudomonas pneumonias that you see in cystic fibrosis patients? And no, I won't give you multiple choice on that. Stranin. Estranin. A lone representative of the monobactams. All right. Do you guys remember in micro how we tested for antibiotic susceptibility? Remember the little disc we put down? Remember what that test is called? In the hospital, they'll probably call it a D test. But in micro parlance, it's called a Kirby-Bauer test. Kirby-Bauer. So just remember Eddie Bauer, the sports guy, and his brother Kirby. Eddie and Kirby-Bauer, Kirby-Bauer test. All right. Well, there's our quiz for the day. Grade yourself and see how you did. All right. Now we're going to talk about the fluoroquinolones. The fluoroquinolones inhibit topoisomerases. Topoisomerase. Who can tell me what a topoisomerase is? When does a cell need topoisomerases? Topo sounds like topographic, topology, maybe, yes? So topoisomerase, do a little etymology there. You're going to have to speak up. Right, topoisomerase. So what does it work on? What does it do? Yes, and what specifically does it do, Elizabeth? You're close. Helicase separates the strands. But in a circular molecule, what happens as you start to separate the strands? The molecule supercoils. You get more tension on the molecule, it gets harder and harder and harder to pull the strands apart. Topoisomerase goes ahead of the replication fork and takes the tension out of the molecule. And the main topoisomerase in bacteria is this molecule called DNA gyrase. And DNA gyrase in bacteria has two subunits, the A subunit and the B subunit. And the fluoroquinolones bind to the A subunit and completely shuts down the activity of that enzyme. That prevents DNA synthesis. It also prevents transcription. It also prevents cells from being able to repair damage to their DNA, and it results in cell death. So notice these drugs end in floxacin. Floxacin. If you see floxacin, it is a fluoroquinolone. And the structure is shown there, and you can see the fluorine there. And if you change the R groups there, that gives you different fluoroquinolones. So these drugs are broad spectrum. They're quite broad spectrum. They're very effective against enteric bacteria, very effective against things like Haemophilus, effective against Legionella, effective against Neisseria, Moraxella, even Pseudomonas species. One in particular, moxifloxacin, is also effective against tuberculosis, Mycobacterium tuberculosis. Resistance to fluoroquinolones is due either to mutations in the gene that encodes the A subunit of DNA gyrase, or due to efflux pumps that just pump the medication out of the cell. That's how you get resistance. Fortunately, resistance to these drugs does not occur all that often. So treatment failure is usually not an issue if your organism is susceptible in the first place. So these are broad spectrum antibiotics that have excellent bioavailability. Essentially, most of them 100% or close to it. They're pretty well tolerated, but they have a list of adverse reactions. We'll go over them because of that. They're not first line anymore, but they are first line for certain things, as we will see. So read this list with me, please. Ciprofloxacin, moxifloxacin, gemifloxacin, ofloxacin, levofloxacin, and delafloxacin. Ciprofloxacin is the granddaddy of this group. That was the first one of this group that was discovered. The newer fluoroquinolones include gemifloxacin, levofloxacin, and moxifloxacin. These have improved effectiveness against gram-positive cocci, like Streptococcus pneumoniae. Because of that, those three, levofloxacin, gemifloxacin, moxifloxacin, they're typically called the respiratory fluoroquinolones, since they're often used to treat hospital-acquired pneumonias. As a general rule, most of your fluoroquinolones are not effective against MRSA. So this shows you the spectrum. You can see the spectrum is quite broad. So ciprofloxacin, as you see, is not very effective against things like staph or Streptococcus pneumoniae or anaerobes or enterococci. Those respiratory fluoroquinolones, they're quite good against enteric gram-negative rods. Streptococcus pneumoniae, atypicals, Haemophilus, Pseudomonas, levofloxacin is particularly good against Pseudomonas. Methicillin-sensitive Staph aureus, not so good against anaerobes except for moxifloxacin, and not so good against enterococci. There is, however, a fluoroquinolone called delafloxacin. And delafloxacin has high potency against gram-positive bacteria including MRSA. All right, so some side effects. There are some CNS side effects, but these only tend to occur in older patients. So dizziness, confusion, hallucinations, stuff like that. That's usually restricted to the elderly. They can prolong the QT interval, but typically only in patients with pre-existing heart conditions. So you might need to screen your patient for these things. And many older patients take these drugs and don't experience these, but some do. Musculoskeletal problems, this is the one you want to circle. They can cause tendon rupture. The older you get, the larger the risk. Also, the risk is higher if the patient's also on steroids. So let's say, let's pretend Brooke, that was your foot?
Yes.
Right. Okay. All right. Next time I'll kick harder. Let's say Brooke here is at a clinic. She's the night nurse for the drop-ins, and some dude comes in and he's got awful sinus infection, and he's waving this bottle around. He says, "This augmentin they gave me, it's not working. Can I have something else, please?" Because you can tell he's really congested. And so Brooke sits down and says, "Okay, here, let's see. Tap those sinuses. Oh yeah, they're loaded. A lot of pain, and he's got a little bit of a fever. And you check, it's red back there. It's clear. Okay, Mr. Jones, you want any other medicine? Oh yeah, I'm on these corticosteroid suppositories for my hemorrhoids." Next in line would be levofloxacin. You want to give him levofloxacin? If you can, but you're going to have to emphasize you can't lift anything heavy. You can't go for long runs or something like that because your risk for tendon injury is increased. So if he's a couch potato, it's probably not a big deal. But if he's active, especially if he's got a job where he lifts a lot, either that or he's going to have to get off the corticosteroids, in which case he has to live with hemorrhoids, which is not fun. So that would be a judgment call. But that would definitely pop on that person, especially if he's like 58 years old or something like that. Then you might say, you're on steroids. This is going to cause some higher risk of causing some tendon issues. All right, photosensitivity can be an issue. Again, sunscreen, long sleeves, usually not an issue. Blood glucose disturbances. This is more the case in diabetics. It tends to cause high or low blood glucose levels, so it messes with the blood glucose. Can also cause some developmental issues. So if your lady is pregnant, that is a contraindication. So does every woman who come in needs a pregnancy test before you give her levofloxacin? No. If she's past menopause, she doesn't. Now, what if she's reproductive age and you say, you know, birth control, anything like that, you're sexually active? No. What if you don't believe her? You give her a pregnancy test? Guys, literally, it's pee on a strip. It's easy. Urine sample, dip it, 3 minutes, tops. So in that case, you probably should. What, don't you believe me? Well, it's not, that's not the point. Inside, you're saying, no, I don't. But keep in mind, if someone is potentially pregnant, now you have two patients you have to be aware of. Very good. Fluoroquinolones should not be taken with any sort of mineral supplements. Don't take them with iron. Don't take them with zinc. Don't take them with calcium pills. That also means don't take them with antacids or milk or multivitamins or something like that. Now, ciprofloxacin and levofloxacin are active against Pseudomonas. So, swimmer's ear, which is usually caused by Pseudomonas aeruginosa, oral drops of fluoroquinolones are very effective. And you won't get the side effects. They're also good for eye infections in contact lens wearers, which are usually caused by Pseudomonas. The eye drops are very, very good for those types of pink eye infections because these will also soak into the contact and will kill the bacteria in the contact as well. They're renally cleared, so they're very good for UTIs, particularly complicated UTIs. But, and the NCLEX loves this question, moxifloxacin is not renally cleared. So don't use moxifloxacin for UTIs. And you will need to adjust the dosage in patients with renal dysfunction, except for moxifloxacin. Questions about fluoroquinolones? Now comes the long parade of protein synthesis inhibitors. We'll start with the aminoglycosides. These drugs, except for amikacin and in mycin, aminoglycosides bind to the 30S ribosomal subunit protein S12. They interfere with proper translation. They both interrupt and disrupt translation. They cause cells to make junk protein. Aminoglycosides tend to be bacteriostatic, not bactericidal. Very good activity against gram-negative bacteria, typically. You can use them in combination with a beta-lactam or a glycopeptide or something like that. This is particularly useful if you need the cells to stop making toxin, because protein synthesis inhibition will prevent cells from making toxin. They have no activity at all against anaerobes because the uptake of the drug requires oxygen. Now, these drugs have issues. Kidneys. If the drug builds up in concentration, they can be quite toxic to the kidney. And this is dose dependent. So you must, number one, stop any nephrotoxic drug that they're taking when giving these. Two, you must make sure the dose is correct. How are you going to detect the beginning of of kidney failure? The easy way, guys. What goes in, what comes out. Input, output. Input, output. How much urine are they making? And you guys thought you needed fancy tests. Oh, as nurses, I have to be concerned about things like pee. Yes, this is the life you've chosen. But how much they're peeing tells you about their kidney function, doesn't it? Elizabeth looks like she's going to be sick. No, you're unfazed, unflappable. Odor toxicity, this is a biggie. Again, dose dependent. Do you guys remember the little tests I showed you in Pathophys where you rub the tragus and whisper into the other ear? Those are kind of dime store hearing tests. First thing you might notice, you're talking to the patient, and the patient is either struggling to hear you or it's clear that they're not understanding you. Then you do the little dime store hearing, hearing test. Do that as a baseline. Now, if your patient comes in and they don't hear very well in the first place, that's a problem. That's why as you rub the tragus and you whisper into the other ear, you can whisper a little bit louder. Again, any type of hearing loss that you detect, you need to tell the provider because they might need to stop the drug. At high doses, the drugs can also cause some paralysis. Also, pregnancy is an absolute contraindication for these drugs. So the two biggie for aminoglycosides, hearing, kidneys. Hearing, kidneys. A few fun facts about aminoglycosides. They're not very well distributed to some tissues. The biggies are the lungs. Not well distributed to the lungs. You always adjust the dose according to the patient's body weight. And you might need to do draws to check drug levels to reduce the risk of toxicity. And if you combine them with a big gram, that can be very effective for treating certain types of gram-negative infections. In fact, they are used that way. The first line for some infections, for example, plague, tend to be first line for plague. Also tend to be first line for tularemia, caused by Francisella tularemia. That's one you get from skinning wild animals and all that sort of stuff. Questions about the aminoglycosides, anyone? The ones used the most are definitely gentamicin. Tobramycin tends to be used ocularly. Neomycin tends to be used for, neomycin ointments for band-aids and things like that. Streptomycin would be number 2. Yeah. Tetracyclines and the glycylcyclines. So tetracycline is the granddaddy. Unfortunately, it's not used a lot anymore today because it doesn't work very well. Then there's doxycycline and minocycline. There are some new ones now that are not listed on here. There is Saracycline is used topically for acne. There's also omadacycline. Omadacycline is new and it's very broad spectrum. It is used for massive GI infections. I don't think I spelled that right. Erftacycline, ervatacycline. I don't, there might be an A there. Need to look that up. It's either erftacycline or ervatacycline or something like that. That is also very broad spectrum. Okay, this is going to bug me for the rest of my life if I don't figure this out. Oh, come on, man. All right, I can't find it. I will look it up a little bit later. Uh, Tigacycline is slightly different than the other tetracyclines, and it's much broader spectrum. So what are these good for? They're really good for atypicals. Atypicals are things that don't have typical cell walls, things like rickettsia, things like chlamydia, things like Legionella, microbes like that. Tigacycline, as you can see, is really broad spectrum. It hits most gram-negative rods, most anaerobes. It hits enterococci, including ones that are resistant to vancomycin. It hits Streptococcus pneumoniae. The other tetracyclines, again, good for rickettsia. So these are the drugs of choice for all tick-borne infections. So Rocky Mountain spotted fever, typhus, all of those. Very good for that. Minocycline is used a good deal for acne. It comes in a foam that's used for acne and what have you. The big downside with these drugs is that they discolor the teeth if they're given to kids. So they're contraindicated in pregnant women and in children younger than 8 years old. After 8 years old, the enamel, adult enamel, has developed. If you give tetracycline before that, it'll stain the teeth. Minocycline, I said monocycline there, should be change that. That should be an I. Minocycline can cause some dizziness and vertigo. That is probably about a 10% sort of feature. They do cause photosensitivity. That is a very definite case. So use sunscreen. They can cause some irritation of the GI tract, the upper GI tract, particularly the esophagus. Take them standing up, take them with lots of water. You're normally advised to take them on an empty stomach. Tigacycline, they'll give it intravenously, can still cause GI upset. Doxycycline can often be taken with food. That will tend to decrease the gastrointestinal irritation. However, food does decrease the absorption of tetracycline. It does not affect the absorption of minocycline or doxycycline. These two drugs that are misspelled here, doxycycline and minocycline, sorry about that, have really good bioavailabilities. And tigacycline, even though it's given IV, has a very good volume of distribution. These drugs, they bind calcium really, really tightly. If they bind the calcium, they don't get absorbed. So same thing, that same caveat that you have with the fluoroquinolones. Don't take them with mineral supplements. Don't take them with iron, calcium, antacids, multivitamins. Don't take them with milk. So the NCLEX might have one of those questions that says, which your patient, you giving your patient doxycycline and talk to them about it, which statement shows that you need to teach them some more. And you might say, I will take this drug with a large glass of milk. The survey says, no, you don't get it, pal. How about a large glass of water, not milk? Those are the tetracyclines. Questions about the tetracyclines? Macrolides include the granddaddy, erythromycin, And then azithromycin, clarithromycin, those are the ones that are used the most. Fidaxomicin is not absorbed, and it's used for Clostridium difficile infections. Very effective against Clostridium difficile infections. It's used for moderate to severe Clostridium difficile infections. These are also protein synthesis inhibitors. I neglected to say that the tetracyclines bind to the large ribosomal subunit, and they prevent charged tRNAs from being able to bind to the acceptor site. These drugs, the macrolides, prevent the peptidyl transferase activity in the large ribosomal subunit from activating. So you don't get peptide bonds on the surface of the ribosome. So they really halt protein synthesis pretty effectively. These drugs, as you can see, are pretty effective against a wide range of microbes. So they're effective against atypicals, they're effective against Helicobacter pylori, effective against Mycobacterium avium, one of those off the beat mycobacteria. Telithromycin has been withdrawn from the market. Praise the Lord. That drug should have never been approved. Not very good against Staphylococcus, not very good against enteric gram-negative rods, with the exception of azithromycin, has some activity. Terrible against anaerobes and really terrible against enterococcus. On the average, these drugs are pretty well tolerated. They can cause some GI disturbance. That's not very common. There are rare but serious hepatic events associated with particular macrolides. The big one was telithromycin. That's why it got pulled from the market. So hepatic events are really not that common. They do prolong the QT wave at high doses, but that's dose dependent. The worst offender is erythromycin. These drugs will inhibit cytochrome P453A4 except for azithromycin. So if your patient is on a statin and they take a Z-Pak, no worries. Sorry, they're on a statin like atorvastatin that's metabolized by cytochrome P453A4. No worries, because azithromycin does not inhibit cytochrome P453A4. So azithromycin is the one with the really long half-life. So that's why you do the high dose and then one pill every day for 5 days. That's a Z-Pak. And it takes advantage of the fact that azithromycin has such a long half-life. Very convenient. These drugs are bacteriostatic. They're not bactericidal. So they're not appropriate for conditions where bactericidal activity is really required. The PrevPak is a combination treatment of 3 drugs. One of them is clarithromycin, and it's used to treat Helicobacter pylori infections in people with peptic ulcer disease. Remember, peptic ulcer disease caused by Helicobacter pylori requires the combination treatment, 2 antibiotics and a PPI. Azithromycin is very effective against traveler's diarrhea. Now, typically, you don't treat traveler's diarrhea, but say a patient is going on, a mission trip and they don't want to be stuck in the bathroom, to not put too fine a point on it, for 2 days while everyone else builds the house. They can take azithromycin. It will keep the traveler's diarrhea at bay, and then it will it'll go away. Fidaxomicin, as we said, is unabsorbed and it's used for GI infections. Questions about the macrolides. Macrolides have very good bioavailability. Linezolid is the founding member of the oxazolidinones. There's now a new member of this group called Tedzolid, Tedzolid, Tedzolid. These drugs tend to specialize on gram-positive bacteria. They do have activity against some atypicals. They do have activity against Mycobacterium tuberculosis. They're lousy against gram-positive bacteria, and they're lousy against anaerobes. This drug is unusual in that it inhibits an initiation step in protein synthesis. It's the only protein synthesis inhibitor that inhibits initiation of protein synthesis. That's significant because initiation of protein synthesis is quite different in bacteria relative to eukaryotes. So it prevents the 30S and 50S subunit from being able to come together. The drug is generally well tolerated, but if you're on it for more than 2 weeks or more, it can start to cause bone marrow suppression. And you can get thrombocytopenia. What happens if you get thrombocytopenia? What happens to your ability to clot your blood? It goes south, right? So CBCs to check platelet numbers. Prolonged therapy, again, can cause peripheral neuropathy. These drugs, both drugs, tetracyclines and linezolid, both have very high bioavailability. Linezolid, not so much tetracycline, acts as a monoamine oxidase inhibitor. So if you give it with other serotonergic drugs, it can cause serotonin syndrome. It's also new, so it's expensive, but it's very good for MRSA and other types of drug-resistant gram-positive bacteria. A question about linezolid, tetracycline? Yet? Okay. Metronidazole, tinidazole, these drugs are specialty drugs for anaerobic bacteria. Anaerobic bacteria. So when I say metronidazole, think metro, I'm going deep down where there's no oxygen. I'm taking the metro down to no oxygen level. I'm taking the metro down to the depths. It's silly, but you'll remember it, right? Please tell me you remember it, please. So if you look at what they're good for, all those are anaerobes, gram-positive and gram-negative anaerobes, Clostridia, Bacteroides, Fusobacteria. They're also effective against Helicobacter pylori, except the American College of Gastroenterologists just put out a letter earlier this year saying that metronidazole is no longer recommended for Helicobacter pylori because there's widespread resistance now against metronidazole. It was overused. It doesn't have a lot of activity against the types of anaerobes that might reside in your mouth. Tinidazole tends to be used for eukaryotes. So Giardia and Amoeba histolytica, good for those. So this drug is reduced by an enzymatic complex that's only found in anaerobes, the pyruvate ferredoxin oxidoreductase system. The nitro group of metronidazole, it has a nitro group, captures a bunch of electrons and becomes a free radical that chews up proteins and DNA. So you can see why it's specific for anaerobes, because it's transformed into the active form by an enzyme complex that's only in anaerobes. And this diagram is meant to show you that. The metronidazole receives the electrons from the ferredoxin. There's your pyruvate ferredoxin oxidoreductase. Now the reduced metronidazole is going to chew up proteins and DNA. This drug will tear up your stomach. You get on metronidazole, make sure there's a bathroom nearby. Many people also report a metallic taste in their mouth. It'll change the way food tastes. Another feature that can happen sometimes with metronidazole is the tongue can turn black. So you might get a call from a patient, they're freaked out. They say, my tongue is black, I'm dying. Reassure them that's the metronidazole, it will go away. Dose-related reversible peripheral neuropathy is reported, but only occasionally. That goes away. Their sense of balance can be affected, and in rare cases, you get confusion and/or seizures. In women, there'll be vaginal itching or discharge. That's if you use it to treat Trichomonas vaginalis, which is the drug of choice, or Gardnerella vaginalis. Runny nose, swollen sore tongue that turns dark. Do not take metronidazole with alcohol. You'll get a disulfiram activity. And with the diarrhea, you'll puke your guts out. Metronidazole also potentiates the effect of warfarin. So warfarin will have to be reduced if they're on warfarin as well. The drug has very good bioavailability. And resistance occurs, but it's not terribly common. However, treatment failure against Clostridium difficile is not uncommon because that little booger can make endospores, and the endospores are resistant to the drug. So be careful when using this drug to treat Clostridium difficile enterocolitis. So it's great for abdominal infections caused by anaerobes. It's great for Helicobacter pylori infections, at least it used to be, not anymore. And it's good for Giardia. And it's a drug of choice for mild to moderate Clostridioides difficile infections. Okay, questions about any of the antibiotics we've just covered? Anything that's unclear, anything you want more information on? No? All right. Then we'll take our 5, and then we'll start on drugs for some honorable mentions for UTIs, drugs for Mycobacterium tuberculosis, and then the antifungals. And then we'll do cancer drugs, and then we'll be done. Yeah. Okay, take 5.
Yeah, but old file then is question. Yeah. My other question is do you have any cholesterol artery disease? It's supposed to be cholesterol. Sorry, coronary artery disease. This was like, I went to go to the coronary artery one. I was like, wait a minute, I think this is supposed to be 2 different tabs.
Yes. Those should not be one and the same.
Okay. Oops.
Mister? Most part? Oh, yes.
I'm not sure yet. She just found it. So,
Eyewash.
yeah. It doesn't right now. It wasn't saying. She has an opinion. Like, for surgery. But it's just so like it's very long. But I don't think it's it doesn't sound like surgery. Surgery. Would that make us have another I mean, happy thought. Yes. Yes.
Of course.
It's not exactly 100 based on all the sections.
Yeah.
So I think the numbers are
I'm
already.
like, why? I did not see that. That's hilarious. I just don't do it. Oh, I'm not. A bunch of my friends.
So keep me questions in by tomorrow.
If we can, like, you don't have to. I mean, I got exams to take on Friday, so if I'm gonna be honest, like, I won't start studying for this till Friday. So if we want to, by Friday. That's what I was kind of thinking. It was by Friday. Yeah, that gives you all weekend.
We have. And
But I know third of way through. But which doc is it? Are there two outline?
there, it's
thinks it.
just.
Okay, so it's fine. I was just really
Yeah.
confused. I looked at it like
The other one is, the other one is a massive question bank if you want to study that feasible material. If there's like 200 questions.
it's all of our quiz questions we've ever created.
No, that one,
Hey, guys, don't forget, after the final Wednesday, you're invited over to my house. It's in walking distance, easy walk. And my wife will have chicken wings and meatballs, and there'll be ice cream sundaes. And if the weather's nice, please, Lord, we'll just be outside and we'll have the chairs out and some blankets down. You can sit on the grass and pet the cat. And if the cat comes to you, the cat may not come to you, but she did last year. She came to people. And just hang out. You can stay as long or as short a period of time as you want. Everyone's invited. And I know Brooke, you'll be gone, but I'll eat some chicken wings in your honor. And so will Elizabeth. You'll have some chicken wings in Brooke's honor, right? Yeah, you'll have an extra chicken wing. And then you'll eat a sundae and take a picture, send it to her and say, wish you were here. Oh, okay, that could be fun.
No idea what it's like. I just
Okay.
got it. So I haven't really played it, but
Now,
it's just like the normal.
Do you guys this semester have nutrition?
nutrition right
And the nutrition final is the next day or it's Monday? Well, wait, don't you usually do a feast where you have to, you already did the feast. What was your cuisine?
Oh, we were in Thailand.
Italian? What was yours? That's easy. You took it to Jackson. Okay. Japanese. Okay. So sushi and cool. Isabella, you in nutrition? What was your cuisine? Sorry? Ah, Thai. Oh, very cool. Okay. Soldier on, shall we? These two drugs, the nitrofurans and fosfomycin, are only to be used for, read it with me, uncomplicated cystitis. Don't use them for anything else. They do not achieve a high enough concentration anywhere else to be of any use anywhere else. But for uncomplicated cystitis, which most of the cystitis infections that you guys will treat will be just that, uncomplicated cystitis. They're very good for that. So these particular drugs, as you can see, they're good for Staphylococcus saprophyticus, good for E. coli, pretty good for most of the gram-negative enterics, good for a lot of enterococci, and also for Pseudomonas and Serratia. Not so good for Acinetobacter. But fortunately, Acinetobacter doesn't cause a ton of UTIs. Side effects. If you take them with food, the gastrointestinal disruptions that have been reported seem to go away or go to pretty near nothing. Nitrofurantoin, which is one of the nitrofurans, rarely can cause pulmonary fibrosis or acute pneumonitis. So, what are you going to do to check for that? Can you put a pulse oximeter on their finger? If they're having some labored breathing, you can also determine their RR, not railroad, but respiration rate. See, it doesn't have to be complicated. It's amazing what a few vitals can tell you, right? You're supposed to agree with me, but anyway. Fosfomycin attacks the cell wall. It attacks an enzyme that's involved in making the subunits for peptidoglycan synthesis, the particular MIR-A enzyme. By inhibiting MIR-A, it inhibits cell wall synthesis. So the drug prevents the synthesis of these peptidoglycan precursors. And without the cell wall, you run into some problems. The cell, of course, dies. So it is bactericidal. Nitrofurans are primarily bacteriostatic, but the beauty of nitrofurans is that, number one, you don't get concentrations that are high enough anywhere except in urine. They attack bacterial flavoproteins, so they form free radicals that damage DNA and proteins. They work a little bit like metronidazole, but they are reduced by very commonly available bacterial flavoproteins. But they're not going to cause any sort of activity unless they build up to high enough concentrations. The only place that happens is in the urine. So don't use these drugs in patients with renal dysfunction because you won't get high enough concentration in the urinary tract. Both drugs are to be used for short durations, but they have to achieve high concentrations in order to work. Nitrofurantoin comes in two forms. There's macrodentin and macrobid. One is 4 times a day, the other is twice a day. Macrobid is definitely the one that gets used the most. Fosfomycin comes as a powder. You take the powder, you mix it with juice or milk or water, whatever, and you drink it, and it works just fine. Do not use these drugs for complicated cystitis. Don't use them for pyelonephritis. Don't use them for urosepsis. If you do, as it says there, that is a treatment failure waiting to happen. Don't go there. It's not pretty. Clindamycin is another protein synthesis inhibitor, but you'll notice that this drug has very good coverage against anaerobes, particularly gram-positive anaerobes. So it's really good against Streptococcus pyogenes. It's really good against MRSA, at least some strains of MRSA. It's really good against these other types of organisms that don't like air very much. Doesn't do a hoot of good against gram-positive Clostridioides difficile enterococci. This particular drug has a mode of action that's very similar to the mode of action of the macrolides. It inhibits the peptidyl transferase activity, but it tends to work largely against anaerobes. So it interferes with protein synthesis, tends to compete for the same site on the ribosome as the macrolides and chloramphenicol. Out of all the antibiotics, this is the one most likely to cause C. diff in its stead. So use this short term, and I would tell your patient to eat this with yogurt or some sort of kefir or something that's going to populate their GI tract with lots of good bacteria. And don't use it long term. It can cause diarrhea that tends to be self-limiting. It also will cause a rash. The rash can be pretty bad if the patient gets sunburned. It's a great alternative for staphylococcal infections. This is a really good drug if your patient has toxic shock syndrome because it hits the streptococci and it prevents the streptococci from making the toxic shock toxin. Extremely bioavailable, and if you mix it with the beta-lactam, you get terrific synergistic activity. So it's used for necrotizing fasciitis. Good for skin, soft tissue infections, second line for pneumocystis pneumonias, also used to treat bacterial vaginitis, malaria, and what have you. Okay, questions? Streptogramins, these are a combination of two drugs, quinupristin, dalfopristin. This particular drug combo is designed to hit MRSA and vancomycin-resistant enterococci, and it's very good against those particular organisms. So we have this project. We're looking at MRSA isolates from the nasal cavities of the softball team, and some of their isolates are pretty resistant to vancomycin, but none of them are resistant to this combo. None of them. This combo chews up those MRSAs really, really well. So this is a pretty good drug against those particular species. This combo has no activity against gram-negative bacteria. So these two bind to the ribosome in a synergistic manner. So dalfopristin, as you can see, binds to the large ribosomal RNA and the large ribosomal subunit. It changes the conformation of that ribosomal RNA, and that causes quinupristin now to bind really tightly, and it prevents the 23S ribosomal RNA from catalyzing the peptidyl transferase activity. So it completely shuts down protein synthesis. Downsides of this drug, it can cause phlebitis. So you want to use a big vein. I would say, and I got this actually from a critical care doc. He said, administer this through a central line. Specially trained nurses are now allowed to do central lines in Michigan. Some of you will be trained to do them probably. Myalgias and arthralgias. Elizabeth, what's an arthralgia? Arthritis, arthralgia, joint pain. Exactly. Myalgia, Brooke, what's myalgia? Muscle pain. Good. Muscle pain and joint pain. So these are common and they may limit the tolerance to therapy. They're cytochrome P450 3A4 inhibitors, so they have a fair number of drug interactions. Do not give this drug in normal saline. It'll fall out of solution. Give it in D5W. Again, I got that from a critical care doc as well. All right, so that combo, quinupristin, dalfopristin, is called Synercid. Synercid, that's the name of it. Synercid. The folate antagonists. This includes the sulfa drugs, trimethoprim, sulfamethoxazole, dapsone, pyrimethamine, sulfadiazine, and sulfadoxine. So these two drugs, trimethoprim, sulfamethoxazole, they inhibit two consecutive enzymes in the synthesis of tetrahydrofolate. Tetrahydrofolate is absolutely essential for amino acid and nucleic acid synthesis. From the paraminobenzoic acid, and it is converted to dihydrofolic acid. Sulfamethoxazole inhibits. So it looks like paraminobenzoic acid. It prevents the synthesis of dihydrofolic acid from paraminobenzoic acid. Then trimethoprim is an analog of dihydrofolic acid. It inhibits the synthesis of tetrahydrofolic acid from dihydrofolic acid. So the sulfamethoxazole inhibits the dihydropteroate synthase, or DHPS, dihydropteroate synthase. Trimethoprim inhibits the dihydrofolate reductase, or DHS. You DHPS, DHR, dihydrofolate reductase. These are consecutive enzymes. The dihydropteroate synthase, that's inhibited by sulfamethoxazole, and the dihydrofolate reductase is inhibited by trimethoprim. You can see why resistance is going to be hard to come by, because you have to have mutations in two different genes in order to confer resistance. What are they good for? They're good for Staph aureus, particularly many MRSA strains. They're good for Haemophilus influenzae, good for Stenotrophomus maltophila, good for Listeria, good for Pneumocystis urovecii, good for Toxoplasma gondii, good for enteric gram-negative rods, good for Streptococcus pneumoniae, good for Salmonella, good for Shigella, good for Nocardia. Terrible for Pseudomonas. Pseudomonas has very tight porins, won't let those drugs in. Terrible for Enterococci, because Enterococci don't make their own folate. They get it from you. Terrible for Streptococcus pyogenes for the same reason. Streptococcus pyogenes gets its folate from the host. And it doesn't work against anaerobes either. Adverse effects, rash. That's the biggie. The sulfamethoxazole will cause rash. Dose-dependent bone marrow suppression at higher doses. At therapeutic doses, that's not an issue, but dose-dependent bone marrow suppression is an issue. These particular drugs are not very soluble, so they can precipitate out and cause interstitial nephrosis, leading to acute renal failure. And consequently, trimethoprim can cause hyperkalemia. Now, these drugs are first line for acute uncomplicated cystitis, particularly in women. The drug that you get is a 1:5 ratio of trimethoprim to sulfamethoxazole. When taken orally, they have great bioavailability. They have significant interactions with warfarin, increased bleeding time, so you will need to dose warfarin down. This is not the last time we've heard this. We heard the same thing with metronidazole, didn't we? The NCLEX loves to ask questions about warfarin and antibiotics, so make sure you guys learn those. This drug is really insoluble. If you give it IV, you have to use really large volumes of diluent. So some hospitals won't even give it IV. Questions about folate antagonists? Most of the cases of resistance are due to gene amplification. Gene amplification, where you take the genes for those two enzymes. The dihydroteroate synthase, the dihydrofolate reductase, they take those genes, they amplify them. That's how cells get around it. Yay, drugs for tuberculosis. The tuberculosis cell wall is really unusual. So you have peptidoglycan, but then you have these arabinogalactans. Attached to them are these arabinose polymers, and attached to those are mycolic acids. So unusual cell wall. You have waxes out there that act kind of like a capsule. But turns out this unusual stretch gives you a potential target-rich environment. How, you ask? I'm glad you asked. So one of the first drugs that is used for Mycobacterium tuberculosis is rifampin, also known as rifampicin. This drug inhibits RNA polymerase. It binds to the catalytic subunit of the RNA polymerase and inhibits it. So it's good for most mycobacteria. It's also good for Staphylococcus and Acinetobacter and enteric bacteria. It's really not that good for much else. It also comes in other forms. So there's rifabutin, rifapentine. These particular forms have different half-lives. Now, the drug is generally well tolerated, but it is a massive cytochrome P450 inducer. So it's got a lot of drug-drug interactions. It will also stain all your patient's secretions orange. So if they wear contact lenses, they should probably take them out and wear glasses because it'll stain them orange. If they wear disposables, they're throwing their lenses away every day. Not a big deal. But if they sweat, it'll stain their clothes. When they go to the bathroom and they pee, it's going to be orange. So if you don't tell your patient this, you're going to get a phone call. They're going to be screaming. I went for a run and I wiped my forehead and it was all orange. I've got orange stains going down my back. My pee is orange. I'm dying. Now, is it their fault? No, it's yours for not warning them. So warn them. Hepatotoxicity is rare, but it's been reported. Other side effects that have been reported are rash, nausea, and vomiting. The nausea tends to be, and vomiting tend to be transient. Hypersensitivity has been reported, but it's rare. Rash has been reported too, but it's really not that common. If your patient is on anti-HIV drugs, the induction cytochrome P450s will chew up those anti-HIV drugs really fast. Never use this drug as a monotherapy. Why? Because resistance to it can occur quite quickly. Rifaximin is a non-absorbed version of this drug, and it's used to treat certain GI conditions. It's used for Crohn's disease a lot. Rifapentin is a long-lived version of this drug. It's given once weekly. Rifampin's your drug of choice for tuberculosis, but rifabutin Rifabutin is used for the Mycobacterium avium complex, sorts of mycobacteria. Next is isoniazid. This is active only against Mycobacterium tuberculosis or Mycobacterium concii. This drug inhibits the synthesis of mycolic acids. So it's activated by a mycobacterial catalase peroxidase, and then that activation causes it to form a complex with NAD and the next enzyme, and that NOEL acyl ACP gets blocked and it can't make mycolic acids and the cell wall goes south. So you activate it, and then you form the adduct with the enzyme that makes mycolic acids. So it inhibits mycolic acids. Isoniazid is the only drug that's effective against latent mycobacteria. So latent tuberculosis, isoniazid is your man. This drug interferes with pyridoxine absorption. So peripheral neuropathy can be really bad. Your patient should take pyridoxine supplements. Optic neuritis has been reported. That's not terribly common. Seizures have been reported. They're not common either. Drug-induced lupus has been reported, but that's pretty rare as well. The other thing this drug can do is it can chew up the liver. So get a baseline set of liver function tests and then retest. Again, drug of choice for latent tuberculosis. The drug is metabolized by phase 2 biotransformation reactions. Some people are rapid acetylators, and the rapid acetylators can metabolize isoniazid faster. Bactericidal against the growing mycobacteria, but bacteriostatic against dormant. Do not drink alcohol with this drug. Circle that, put an exclamation point next to it, put a star next to it. The patient can get fulminant liver damage if they drink on this drug. Bad idea. Pyrazinamide also seems to inhibit fatty acid synthase 1, so it works kind of in the same way as isoniazid. This drug will raise uric acid levels, and it can participate gout attacks in people with high uric acid level. Can also cause some joint pain. The hepatotoxicity is dose dependent. The biggest issue with this drug is gout. This drug is only good for the initial phase of active tuberculosis. If you give this drug with rifampin, you increase the hepatic hepatitis risk, and it works in the acidic environment of the phagolysosome. Finally, there is ethambutol. This inhibits those arabinogalactans that we saw. So it blocks production of arabinogalactan. Ethambutol, by and well, is rather well tolerated. But it can cause optic neuritis, where the patient will have decreased color acuity. So you do not give it in children, because children often can't communicate whether or not they're seeing colors very well. Can cause rash and drug fevers in some people. Those are not very common, but they can happen. Does not cause hepatotoxicity. So it's sometimes used to substitute for rifampin. Remember, Tuberculosis treatment will tend to include combinations of drugs. So the main drug combo you give is rifampin, isoniazid, pyrazinamide, ethambutol. You give that for the first 2 months. Then after that, they're just on rifampin and isoniazid for the next 4 months. So you have to treat the patient for 6 months. This drug, pretomanid, was developed by the Tuberculosis Alliance, and it is used for drug-resistant tuberculosis. How it works is not terribly clear. But it's sold under the brand name Delmanid. So it's pretomanid and it's Delmanid, used for drug-resistant tuberculosis. It will tend to cause headache, dizziness, and nausea, but those are pretty minor and pretty transient. Will cause QT prolongation, and it's metabolized by cytochrome P453A4. So in the presence of strong inducers, this enzyme will tend to get chopped to pieces. Bedaquiline is another new-ish anti-tuberculosis drug that inhibits the mycobacterial ATPase, and it is also used for drug-resistant Mycobacterium tuberculosis. So you have a combination of bedaquiline, pretomanid, moxifloxacin, and pyrazinamide. That particular PASM, the BPASM, is used for multi-drug resistant tuberculosis. This drug causes joint pain, headaches, chest pain. It can cause QT prolongation, but usually that's only an issue in people who already have arrhythmias. Liver dysfunction, increased risk of death. Do not use it during pregnancy, and it's also contraindicated in people who are taking strong cytochrome P553A4 inducers, or in people taking drugs that prolong the QT interval. Any questions before we get to the antifungals? All right. Deep breath. Here we go. Fungi have a cell wall. They also do not have cholesterol in their membranes. Instead, they have ergosterol. The ergosterol biosynthetic pathway differs in the last few steps. And those last few steps, therefore, the enzymes have diverged such that they can be inhibited by drugs that do not inhibit cholesterol synthesis in humans. So that's the main target. So is the synthesis of the cell wall. So the first group of drugs are the polyenes. There are two drugs in this group, amphotericin B and nystatin. Nystatin is only used topically. Amphotericin B is very toxic, but it does come in a liposome. It's a little, you get to have these little membranes that contain the amphotericin B. It's a lot more expensive, but it's a lot less toxic. Amphotericin B is very toxic to the kidney. So to attenuate this, you're going to sodium load the patient. You give them normal saline several hours before you're going to give them the amphotericin B. The high sodium will increase the efflux in the kidney. So now if the drug gets to the kidney, it's going to be effluxed a lot faster, and the kidney damage will be a lot less. Amphotericin B binds to ergosterol, and it forms pores. the cell leaks and the cell dies. So it's used for dimorphic fungi and lots of molds. It's used for Cryptococcus neoformans, Aspergillus, many species of Candida. Some activity against zygomycetes, but not very good. No activity against particular species of Candida or Aspergillus terreus. This drug causes violent infusion reactions. The patient will get very cold. So when you think amphotericin B, think blanket. B for warm blanket. You pre-medicate the patient with things like acetaminophen or hydrocortisone, you can attenuate the infusion reaction. The big issue is just the renal toxicity. So if you sodium load, you'll attenuate the nephrotoxicity. This is a drug of choice essentially when you have no place else to turn. Bifluorocytosine is always used in combination typically with other drugs. The fungus takes it and deaminates it to 5-fluorouracil. That gets converted into a triphosphorylated form that gets incorporated into RNA polymerases, and it tends to interfere with their activity. So it interferes with DNA and RNA synthesis. So it's good for Cryptococcus neoformans and a lot of your Candida species. By itself, it's good for some Candida species and Cryptococcus neoformans. It's terrible for Candida krusei, and it's terrible for most other molds. This drug suppresses the bone marrow, and it chews up your gut. Check your CBCs to discern toxicity. Do not use it as a monotherapy for Candida infections because of the rise of resistance. Having said that, I have a friend who had a urinary tract infection with Candida glabrata, and she was given this drug as a monotherapy. To which I said, what is that person thinking? Oh, well, typically you'll combine it with amphotericin B for fungal meningitis. The azoles. These all end in azole. Ketocon azole, flucon azole, itracon azole, voricon azole, posicon azole, your mother-in-law azole, what have you. These interfere with this enzyme, 14-alpha demethylase, that converts lanosterol to cholesterol in our body, but in fungi, lanosterol to ergosterol. That enzyme has diverged enough so that these drugs inhibit the fungal enzyme without inhibiting the mammalian enzyme appreciably. Fluconazole is the best tolerated out of these drugs. Active against Candida, active against Cryptococcus neoformans and Coccidioides immitis. Moderate activity against Candida glabrata and no activity against dimorphic fungi and Candida krusei. It's well tolerated, but it causes a rash, causes some drug-drug interactions, and it can mess with your liver. It's eliminated in the urine. Have you heard of a product called diflucan that's used for yeast infections? That's what diflucan contains, fluconazole. It's a one-shot deal. Now, you get a patient with a Candida infection. Not all people are susceptible to this drug. Make sure you do susceptibility tests. Itraconazole. Very active against most dimorphic fungi, Aspergillus species, Cryptococcus neoformans. Again, not good against molds or zygomycetes. This drug's a negative ionotrope. Diminishes the speed of conduction down the heart. So if a patient has heart failure, it'll make it worse. This drug will mess with your liver. So liver function test before and after. The oral solution that you use to take it can cause pretty robust diarrhea, and it can cause QT prolongation. The big one there is your liver. Watch your liver. Watch your patient's liver function. The IV formula is discontinued. The oral form should be taken with food. It's lipid soluble, so it works best with a high-fat meal. So taking it with a milkshake or something, your patient will be glad to hear that. The absorption consequently can be erratic, but it's a really good drug for dimorphic fungal infections, for histoplasmosis, blastomycosis, coccidioidomycosis, paracoccidioidomycosis, drugs like that, infections like that. Voriconazole. This drug is especially good for Aspergillus infections, but it can also be used for Candida species that are resistant to fluconazole. So it has poor activity against zygomycetes, but it's effective against a lot of the other type of things that will cause fungal infections. This drug, because it's taken with a cyclodextrin solubilizer, that can accumulate in patients with decreased renal function and can affect the kidney. So you want to make sure that it doesn't build up in concentration too high. It can cause visual effects where the patient will see wavy lines and flashing. That goes away. Can cause rash. And again, virtually all of these azoles can mess with your liver. So liver, 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 liver. Very good against fluconazole-resistant Candida albicans. But this drug messes with cytochrome P453A4. So check those DDIs. First drug of choice for Aspergillus, it's hepatically eliminated. Posaconazole. This drug is really good for zygomycetes. People who are on high-dose steroids can get really, really severe sinus infections with rhizopus or mucor, and they can get these zygomycete infections. These infections can cause your nose to fall off, and that happened during COVID. People on high-dose dexamethasone, they got these awful zygomycetes infections, and their noses fell off. They're really disfiguring, really sad. This is your drug of choice if you get a zygomycete infections. Again, it's the same thing. Liver, 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 liver. The drug comes in an oral suspension. You have to take it with food. Again, high-fat foods, low pH foods. Oh, they get to eat high-fat food. Lasagna with soda. The drug will get absorbed really well. Don't take proton pump inhibitors with it. That will prevent absorption because it needs acid for absorption. I know we're over time. Just let me finish this, please. Isuvaconazonium sulfate is kind of new. This one is used to treat invasive Aspergillus and zygomycete infections. It's got a long list of side effects. I mean, guys, just so you're going to use this drug if everything else, if you know, help, this is the drug you use. The drug's a prodrug. It's got lots of drug interactions. Again, liver, 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 liver. Okay. I will podcast echinocandins. That way you guys don't have to stay here past 9 o'clock. But it's only 3 slides. Let me just go through it, or Okay. Some fungi have this polymer in their cell wall called beta glucan. Beta glucan is made by a beta D glucan synthase. The echinocandins inhibit that enzyme. Now, they only work, therefore, on fungi that have this polymer in their cell wall. You'll notice that all these drugs end in fungin, caspofungin, micafungin, anidulafungin. So they're very effective against Aspergillus in Canada. Typically, fungi that are in the ascomycete group, they're very effective because the ascomycetes tend to have the beta glucan. They have poor activity against non-Aspergillus molds and Cryptococcus. Cryptococcus is a member of the Basidiomycete group, not the ascomycete group. So non-ascomycete group fungi, these drugs are not very effective against them. But they have a good safety profile. All of these drugs are administered intravenously, and they can cause histamine-related infusion reactions. That's uncommon if you pre-treat with Benadryl. That won't happen. Hepatotoxicity has been reported, but it's not that common. So those two drugs, caspofungin and micafungin, hepatically eliminated. So they're good for people with renal issues. And andulafungin is degraded in the plasma. They're less active against Candida parapsilosis. Drug interactions with immunosuppressants like sirolimus and cyclosporin. So watch if the patient's on those kinds of drugs. Yay, we finished. Okay, Monday, anti-cancer drugs. Anti-cancer drugs, okay? Thanks for being troopers. I will see you guys on Monday. And Brooke will have the test with the secretary for you to take it. Yeah. In fact, Ava might take it at the same time as you because she has it. She's taking it after class. So our class ends at 12. She's taking it around 12. So. Okay, so you'll be two ships passing in the night. So
thank you.
All right.
You leave Monday or Tuesday? You leave Monday.